Sunovion, committed partner of the Epilepsy Foundation, Eastern Pennsylvania, and talkaboutit.org, proudly supports this podcast to help raise epilepsy awareness and understanding. So, Nancy, now we're going to get more into your story.
Let's do it.
So, I think a good place to start kind of off the questions was maybe just some of your experiences, a bit of your journey with
How
epilepsy.
did this whole game start?
Yes.
Well, I have adult onset epilepsy, which means obviously I did not have this struggle as a child. About 10 years ago, in my early 30s, I was woken up and told that I just had a seizure. My response was, "What do you mean I had a seizure? I don't have seizures." My head was throbbing. Something had happened. And I went to the emergency room, and it took a long time to find Dr. Skidmore and to start to have some answers.
Epilepsy And is a podcast sharing stories of hope from the patient community and the latest in medical advances. 1 in 26 people will develop epilepsy, but it's more than seizures. Join the Epilepsy Foundation, Eastern Pennsylvania, and become part of the conversation.
Hello, everyone. My name is Missy Dalloway, and I'm the host of Epilepsy And. On this episode, we talk to Nancy Goldfarb. Nancy Goldfarb was born and raised in Philadelphia and pursued her education in New Orleans and Pittsburgh. After returning home, Nancy quickly pursued a career in public relations and governmental affairs. In her mid-30s, Nancy began to have seizures. She was quickly diagnosed with adult-onset epilepsy. In 2015, after many years of unsuccessful treatment, Nancy had a left temporal lobectomy. She is now strongly and successfully rebuilding her life with a reduced amount of seizures. A lot of people think that if you have epilepsy, you were born with it or developed it as a child. But the truth is, 1 in 26 people will be diagnosed with epilepsy in their lifetime. Anyone can develop epilepsy at any point, at any age. And as the population grows older, more and more adults will develop epilepsy. Nancy is one of those people. To help her tell her story, Nancy is joined by her neurologist and Jefferson University physician, Dr. Christopher Skidmore. On this episode, Nancy explains what it feels like for her to have a seizure, how her superpower is something called an aura, and why the last thing she wants you to do is put a stick in her mouth.
The seizures were in my REM sleep in the beginning. So I was lucky enough not to have to, I always look for the positives. I was lucky enough to not have to worry about being out and about through my day. Now that has since changed, but when I started this journey, I was having them in my sleep and waking up in my bed. And 10 years later, it is still a struggle. It's still frustrating because the one thing about epilepsy is it's hard. I can speak from my own experience and from other people I've spoken with and my doctors that you can't really find the cause. Well, you have epilepsy now because of this. No.
And that struggle of not knowing what caused it. So it's not uncommon that you want to know, as humans, we want to know why. We want to know why X is happening to me, whatever that X is. And in the case of seizures, you want to know why are you having seizures, especially when a lot of people don't realize that epilepsy can come on at any point in life. And so it's not uncommon the individuals that start having seizures as an adult, and focal epilepsy can begin as an adult. They want to know why.
When people want to know why, they start to search for answers. Nancy's search helped her find Dr. Chris Skidmore. Dr. Skidmore is an associate professor of neurology at Thomas Jefferson University and a member of the Jefferson Comprehensive Epilepsy Center. He is also the chair of the Professional Advisory Board for the Epilepsy Foundation of Eastern PA and the vice chair for clinical affairs for the Department of Neurology at Thomas Jefferson University.
I found Dr. Skidmore and we did a lot of work together. MRIs, EEGs, neuropsych exams.
Even after all of those tests, doctors can sometimes have a tough time discerning why a patient is having seizures. Dr. Skidmore explains.
And so, unfortunately, when you do that MRI, we're trying to understand why. But even despite the great advances we've made in imaging technology, still roughly half of people have a normal MRI of the brain.
If I was able to look at their brain under a microscope, I may see something that the MRI missed.
But it's not uncommon what you said about finding it frustrating, that you want to know why and I can't tell you why. That is a very common thing that patients kind of complain or feel.
And it is frustrating, but again, it would be more frustrating if it couldn't be controlled. So I don't know the cause, but I know how to care for myself and control them. So it's a mixed bag.
When someone has a seizure for the first time, it can be very confusing and scary. A lot of people's minds don't immediately jump to epilepsy, and the event can be blamed on something else, like panic attacks or fainting spells. Thankfully, neurologists like Dr. Skidmore can use clues to help figure out what is happening in a patient's body.
Panic disorder and the panic induced by a seizure can be relatively similar. Panic disorders usually last for minutes or longer, whereas seizures tend to be, the average seizure is under 2 minutes, right? So when I hear a history of panic attack that comes on and it lasts 30 seconds, that's unusual for that to be a true generalized anxiety disorder or panic disorder due to a psychiatric condition. We start wondering, is it more likely that this could be a seizure, and start to ask questions.
Let's do some math. If you are an average American, you have a 1 in 100 or a 1% chance of developing type 1 diabetes. You also have a 1 in 133 or less than 1% chance of having celiac disease. But you have a 1 in 26, almost 4% chance of developing epilepsy. In fact, more people are living with epilepsy than autism spectrum disorders, Parkinson's disease, multiple sclerosis, and cerebral palsy combined. With any disease or condition, it is important to understand what it is and what are the risks.
So when you're talking about epilepsy, there are two broad categories. There's generalized onset and there's focal onset. So the generalized is easier to kind of conceptualize. And so imagine that a seizure is an electrical storm in the brain. And that electrical storm, when we look at it on EEG from the scalp, those wires that we put on the patient's head, the electrical activity is diffusely over the entire brain. Whereas in a focal onset seizure, the abnormal electrical storm starts in one spot and then can still spread out over the entire brain. But the concept is it starts in one spot and spreads. And it could be multifocal, so it could be in multiple spots. So our brains are separated into different lobes, so frontal lobe, temporal lobe, parietal lobe, occipital lobe. And so we'll often hear people have temporal lobe epilepsy or frontal lobe epilepsy. So all of those patients have focal onset epilepsy. And then the doctor has determined that the seizures are starting in the frontal lobe or in the temporal lobe. Now, people can have bitemporal lobe epilepsy, or they can have epilepsy from multiple lobes, which we would call multifocal epilepsy.
So that is what's happening inside your brain. But how can doctors look at what is happening without using invasive procedures?
Primary generalized onset epilepsy is defined based on the pattern of electrical activity seen on the EEG. When we look at an EEG in somebody with primary generalized epilepsy, the abnormal electrical discharge is spread out over the entire brain simultaneously. This differs from focal onset epilepsy, where the abnormal electrical activity may start in one spot or multiple spots. It can still spread out over the entire brain, but the concept is that it starts in one location.
So how can doctors use imaging technology to tell what type of seizures a patient is having?
So if somebody has generalized epilepsy, all the seizures should look the same, and they're going to be consistent with that generalized seizure. Now, that generalized seizure could be a generalized tonic-clonic seizure. It can be an absent seizure, which is a blank staring spell. So those are a couple of possibilities of common types of generalized epilepsy. Whereas in a focal onset seizure, the behavior can look different, but is going to be relatively unique to the location. So if a seizure is starting in one temporal lobe and the person also has a history of frontal lobe epilepsy, often the seizures are going to look a little bit different, but at each time for each individual seizure, it's usually starting in one spot. But the challenge is that seizures actually can spread from one spot to the next. And so you can have a seizure, let's say, that starts in the temporal lobe that then spreads to the frontal lobe and triggers that frontal lobe seizure as well. Our brains are connected, right? So our brains are giant supercomputers, and all the different parts of the brains are electrically connected to each other and then connected to our bodies. When you have that short circuit in a computer board, if it's just in one spot, it only causes one problem. So let's say the problem is in the monitor. So you have a problem with the monitor. But the problem is if that abnormal electricity spreads to other spots, then you have to start having problems with the speakers. Then you start having problems with the mouse. Then you start having problems with the keyboard. So that's akin to as the seizure begins in one spot and starts to spread out over the brain. When it's spreading, that's when we're seeing the symptoms of the seizure as it spreads to different locations. And the more brain tissue that's involved, the more severe the seizure is going to be. And obviously the worst type of seizure is the generalized tonic-clonic seizure, which some people still call a grand mal seizure. So a generalized tonic-clonic seizure of focal onset seizures and a generalized tonic-clonic seizure of a generalized tonic-clonic seizure often can look similar because ultimately it's the same final output in that the seizure discharge is spreading over the entire brain.
What's the very first thing you think of when you hear the word epilepsy? People who don't have a personal experience with a disease or condition are often influenced by what they see on movies and in TV. Unfortunately, this isn't always a fair representation and can often lead to misinformed beliefs and negative stereotypes.
My unfortunate first thought as to what are the stereotypes or stigma is that people don't really know what to expect. There are few stigmas, and that's due to a lack of education. People have no idea what to expect. The answer I get when I tell people I have epilepsy is, "Oh my gosh." So they think they wonder why I'm out of the house, that it's so debilitating that I should still be in bed. They're shocked that I'm quote unquote normal, that I don't have somebody holding my hand everywhere I go.
Even among medical professionals, it's not always easy to tell if someone is having a seizure.
And this is the challenge. Because our brains are amazing and can do so many different things, focal seizures can look like a lot of different things. Because they can look very varied and different depending on what part of the brain they're coming from, it's not uncommon that even other medical professionals can see a seizure and go, wait, was that a seizure? What was that? And then now you put somebody who's out in the public and having a seizure out in the public, and some of our patients get arrested after a seizure because people that show up confuse the confusion afterwards with not following commands. Well, yeah, they can't follow commands because they just had a seizure. People get looked at like they're bizarre because they have different, had an unusual behavior on the bus or on the train. And so that's the challenge, because when most people think about epilepsy, they think of the generalized tonic-clonic seizure or the grand mal seizure. That's what's been depicted most in media, in movies, and theater, and things like that. And so I think you're right. I think it is an educational campaign to understand that, first of all, there's lots and lots and lots of people in the United States with epilepsy, right? Super common neurological disorder. And they've interacted with tons of people that they had no clue they ever had epilepsy, because the seizures and the epilepsy don't define the individual. And for most of our patients, it's something that we work to achieve to get them so that you're living with your epilepsy. You're taking your life in your own hands and doing the things you have to do. And it's my job to give you the tools and the treatments necessary to allow you to achieve that. And that's truly, I think, what we believe.
I don't want to introduce myself to someone and say, "Hi, my name is Nancy and I have epilepsy." Right. So
you want to just be Nancy.
Yes, I just want to be Nancy, not epileptic Nancy. So because I think that those stigmas or that miseducation goes along with it.
Life is full of things that can be hard to understand until you have personally experienced them. The birth of a child or the loss of a loved one. The best Nancy can do is explain what her personal experience is like having a seizure, how it will look to others, and how she wants others to respond.
The first thing I tell them, it's scary. It's scary to watch. But I tell them that it's scarier than it looks. That I'm going to look like a fish flapping on the floor. My body's going to shake violently. Leave me alone. Don't touch me. If you can't look at me, don't. It's scarier for you than it is for me. Don't expect me to constantly be a fish flapping on the floor. I'm unconscious. Now, if I have an aura, I'm going to warn whoever I am with ahead of time.
Knowing what will happen in the future sounds like a superpower, but for someone living with epilepsy, auras are not uncommon.
A focal seizure may or may not start with what's called an aura or a warning. And so an aura or a warning can be something that the patient is experiencing at the very beginning of a seizure that can give them a clue that they're actually having a seizure.
For me, I get very lightheaded. I get very dizzy. And I feel lucky that I have a warning sign, that I can talk to whoever is around me and let them know that there's a seizure coming on, that I can sit down, that I can prepare for what's to come.
So it's not uncommon that auras can be seeing things, so involving the visual cortex, hearing stuff because it involves the auditory cortex. It can be a funny feeling in your body because it's involving the areas that are responsible for sensation. Or it can be even more complex, things like déjà vu or jamais vu, where you feel like you're reliving a dream or you feel like you're in a familiar situation. These very complex emotional thoughts and feelings, and that's triggering a much larger network in the brain. But these can be warning signs. So sometimes with focal onset, it can start in a very focal place. And that gives us a clue that we might be dealing with a focal onset seizure.
While auras can be helpful to some patients and provide clues to doctors, they can be infrequent and not always obvious to the person experiencing them.
Just last week, I had an aura. Thank goodness I think it was an aura, to be honest. It wasn't followed with a large seizure, but I knew that I could tell my coworkers and remove myself and sit down and wait for that wave to pass. So yeah, it's a warning signal, and it's good to have.
Unfortunately, only about half of people, though, have that warning or aura. Now, a lot of people get confused as to what does the aura mean, and it is actually a seizure. It's just a very, very tiny seizure that has not impaired your ability to interact, communicate, or respond. And then as it spreads, so auras can last anywhere from seconds to minutes, and it becomes important to know that with your doctor, because if you have a very prolonged aura, well, that's one of the driving exclusions that allows you to continue to drive, because if your aura lasts for minutes and is reliable and predictable, then we know that you can safely pull over a car. And so it becomes important to understand that. So the aura becomes very important.
For a lot of patients, a seizure is still unexpected, and they may not be fully aware until some time after it's over.
Sometimes I don't have a warning. Sometimes I wake up and it's all over. But often I do get that aura, and it's nice to know. It's nice to have it. It's nice to know that it's coming. Get ready, prepare.
After that, the symptoms of a focal seizure can be you either lose awareness or you don't lose awareness, what's now called focal aware or focal impaired awareness seizures. The old terms used to be simple partial seizure and complex partial seizure, but to be honest, they were confusing, and the International League Against Epilepsy about 2 years ago now changed the nomenclature. And so now we call them focal aware if you maintain awareness and maintain consciousness, or focal impaired awareness if you lose awareness or lose consciousness. And people can have anything from a bland stare and just be sitting there and seem like they're just staring off into space, or more complex movements where they can fumble with their hands or smack their lips or repetitively say something over and over and over again. And those are called automatisms.
Not all auras are the same. Depending on where in the brain the focal seizure starts, patients can have different experiences.
And it becomes unique because depending on where the focal seizure is starting, they have different symptoms. So if you have a seizure that's coming from the frontal lobe that's close to where motor function is, it's not uncommon that frontal lobe seizures involve motor symptoms, usually unilateral. So if my left hemisphere controls the right side of my body, so I've had seizure coming from near my left motor cortex, it would cause my right hand to twitch maybe at the beginning. And so that we would call motor seizure. And that's a clue usually that you might be dealing with frontal lobe epilepsy. Whereas parietal lobe epilepsy is more about sensation and kind of coordinating or putting feelings and sensory input together. The occipital lobe is where our vision is. And so it's not uncommon that people with occipital lobe epilepsy start with a visual aura. And in temporal lobe epilepsy, it's close to the auditory area. So if it's on the outside of the temporal lobe, it often can start with auditory features. Whereas if it's on the middle part of the temporal lobe, there's a structure there that's involved with fear. And so some people start having a sensation of fear at the beginning of a seizure. And so that's where it gets to the very specifics. And so I always tell the patients and their caregivers, their loved ones, anybody who's witnessed it, to, if you see a seizure, immediately ask the patient what they experienced and then write down everything that you saw, because that's the most important thing for me, is to try to start to figure out the clues that tell us to what we're dealing with. I know that patients have told me before that the aura, again, it takes at least a little bit of the unknown away, because one of the things that's the most scary, and again, this is just from talking to numerous patients, is that unknown of never knowing when the seizure is going to happen. And so at least the aura, especially if they are longer, it does give you that time to prepare for the seizure, mentally, physically, to sit down, get into a safe place, notify your coworkers, the person at the checkout counter that you're about to have a seizure. That becomes very important.
And I tell them to leave me alone. I tell them that it's all going to be over soon enough. Quite frankly, if I've had seizures without auras, I've ended up in the ER, and it's important for me to tell people that that's not necessary, that there's nothing that the hospital can do for me that I can't do for myself. I'm going to get in bed. I'm going to take my medications. I'm going to call Dr. Skidmore and go from there. It's the recovery that's hard for me. It's not the actual seizure. The seizure is going to be hard for you, whoever is standing there watching me. So that's what I tell people. I tell them it's scary. And then I tell them how to handle it. And people are very receptive to all of that. They don't want to see anyone go through that, and they want to help. So as much as you can share, as much as you can prepare. And it's not easy. It's hard to watch.
After the break, Nancy and Dr. Skidmore tell us why the bystanders of a seizure are so important to making a diagnosis and finding an effective treatment.
And then I'm thinking, when you say they're short term, well, not according to the person who saw my last seizure. It was 20 minutes long. And I keep saying to him, Brian, it wasn't 20. Oh, yes, it was.
Sunovion, committed partner of the Epilepsy Foundation Eastern Pennsylvania and talkaboutit.org, proudly supports this podcast to help raise epilepsy awareness and understanding. Sunovion believes relevant education is one meaningful way we can improve the lives of people living with epilepsy. Find out how Sunovion continues to take on tomorrow at sunovion.com. That's SUNOVION.com.
People ask me what it's like to have a seizure, and I often say it's worse for whoever's watching than it is for me. Now, the postictal stage is the hard part for me. Mm-hmm. That's when my body is in pain. That's when I have a horrible headache. But it probably feels like a day and a half when it's a minute and a half for the seizure.
Yeah.
That's the hard part for whoever it is that's watching.
If you've never experienced another person having a seizure, it can be hard to know what to do. Most people want to help, but don't know how.
It's not uncommon that people that witness seizures overestimate the time, because what I'm trying to see is what happens, during the seizure, and we call that the ictal state, when you're actually in the seizure itself. And then afterwards, there's the after effects of a seizure, which we really haven't touched on so far, and that we call the postictal period, so kind of the period after the seizure. And in that state, people can still be unresponsive, not answering questions, sometimes have labored breathing, can act confused and disoriented. And so it's not uncommon that a person who's not experienced with seeing seizures will confuse the seizure itself within that period, what we call the postictal period afterwards. And so that's very, very common.
I was told that my last seizure lasted 20 minutes. And it occurred to me when you were talking that it's a great idea to tell people, if they have to witness this, to pick up their cell phones and record it if possible, to look at a clock and record it, and, be careful, watch the time, write down whatever they see. Because, I had to convince this person that it was not, in fact, 20 minutes, although I understand how it could have felt like 20 minutes.
The other great tool that I use when trying to judge time is, because again, people tend to overestimate, especially if it's your loved one that's having that seizure, is I do a little test where I basically say, we're not going to talk for 30 seconds. And I kind of stare at the person as I'm looking at my watch. And even after 15 seconds of dead silence, people realize how uncomfortable that period of dead silence. And then they realize that they're most likely overestimating the length of the seizure itself.
In stressful situations, people can react quickly based on misinformed information. Growing up, you get all sorts of advice that you believe, even as an adult. If someone is choking, hit them on the back. Or don't touch a fallen baby bird and return it to their nest because their mother will reject them. It may shock you to know that both of those pieces of advice are not actually true and can actually be harmful to the victim. Nancy shares the myth about seizures that bothers her the most.
The most common stereotype or stigma I hear is, should I put a stick in your mouth? I mean, really, I hear, no, I do not put a stick in my mouth.
Yeah, please don't.
Yeah, please leave my mouth alone. But otherwise, not many stereotypes, which I think, again, is due to a lack of education.
Right.
In addition to put a stick in my mouth, a lot of people think that they're supposed to turn me on my side. Do you get that, Dr. Skidmore?
I think that comes from the fact that after a seizure, rarely people can actually vomit. And if you're laying on your back unconscious, then you're not necessarily protecting your airway. And so what we recommend is, after a seizure, if you can, try to just roll somebody on their side. So that way, if they were to vomit, or if there's any excessive saliva in their mouth, that it's kind of coming out of their mouth instead of going down in potentially into their lungs and causing an issue with your lungs. So that's kind of where that comes from. But I think people, they hear seizure, and they're like, oh, I got to turn them on their side. It's actually after the seizure that we want you to kind of try to turn somebody on their side if you can.
It makes sense that people want to help, but just let it go until after.
And as I said, if somebody is shaking on the ground, either put your coat, your jacket, or a pillow underneath their head, or if you can't, hold their head until it ends, because that's what we worry about, are your arms and legs or your head hitting into something that could cause an injury. That's what we basically recommend that people do.
After a seizure is over, information gathered during the event can help doctors make a diagnosis and find an effective treatment. Bystanders can be just as helpful to a patient after a seizure as they are during a seizure.
The seizure first aid, whether it's a focal seizure or a generalized seizure, really doesn't differ. I think the most important thing is to make sure that the patient is safe. If they are kind of unconscious, and on the ground, try to put something soft under their head so they don't hit their head. And just be there, encouraging and supportive of them. Remove stuff that's around them that could injure them. Unfortunately, sometimes people bite their tongue during a seizure. The desire is to try to stick something in their mouth to prevent that from happening. And we know that you should never do that, because the person is most likely to just bite off whatever you're putting in their mouth, and then that becomes a choking hazard, or you're likely to push the tongue and obstruct their airway. So even though it's obviously devastating to see somebody that's actually biting their tongue, you should never intervene because you're more likely to cause more harm than good. And then as the person comes out of the seizure, just kind of rest and reassure them. People can get very confused after a seizure. And so we try to give patients and people space after a seizure a little bit, but obviously you want to keep them safe, but try to give them space, just reassure them and kind of give them that time to recover.
I just want you to tell me I'm okay. That's it.
Yeah.
And
Just having someone there with you.
yeah, it helps. Just opening your eyes, seeing somebody, hopefully, that you know. And even if it's not, unfortunately, and you're, not in your safety zone, it's just, it would be nice to know I'm okay, but that's it. I'll come out of it.
I mean, I think you can get clues from the symptoms that the patient displays or that they report during a seizure, as we've already talked about. So I think the most important thing is to be descriptive. And we all think we have a great memory, but most of us, our memories are horrible, especially in that traumatic situation where you're watching a loved one or somebody you're caring for kind of having a seizure. The most important thing is to, if you have access to a video camera, turn it on while you're kind of caring for somebody. And the second thing is, if you don't, then as soon as it's done and that person's in a safe space, write down everything that you remember. Because obviously when you're in that moment, first of all,
time slows down.
Everyone overestimates the amount of time that a seizure lasts, and the details do matter. And then when you share it with the neurologist or the epilepsy specialist, they can then try to take some of that detail and kind of get an understanding.
In the beginning of this episode, Dr. Skidmore explained the two different categories of seizures, generalized and focal onset. But why is it important to know which type of onset a patient is experiencing?
We've been spending a lot of time talking about focal versus generalized epilepsy. And the question is, why is it important? I think that why does it matter? And I think one of the important reasons why it matters is because if you have generalized epilepsy, so right now in the United States, there are about 7 or 8 anti-epileptic drugs that we can use to treat generalized epilepsy. And then the other 20-something that are on the market are for really focal epilepsy. And so that's why it becomes important for a doctor to try to understand that. Now, some of the drugs overlap and treat both. And so if I'm not certain after meeting somebody, I take their history and I talk to them about what their seizures look like, and we get an MRI and it's normal, which it's normal in about half of the cases. And we get an EEG and that EEG doesn't show us very much, which again, a routine EEG is normal in half of people with epilepsy, just one EEG. If I'm not sure in the office, then I'm going to choose what we would call a broad spectrum drug that can try to treat both conditions. So that's the reason it becomes important early on when you're first diagnosed, is because the doctor is trying to understand what drugs may or may not work for you. Later on, if medicines are not working, there are different treatment options for what we call refractory epilepsy. So those individuals that continue to have seizures despite medicines. There's different options for focal epilepsy, and frankly, there are more options for focal epilepsy than there are for generalized epilepsy, and so then it becomes important again.
I've tried a number of different medications. I think I'm on medication number 3 or 4. I had surgery and had my temporal lobe removed. And I also, in addition to having auras, feel very lucky that we were able to find the part of my brain that was being affected and causing the seizures. And I was 5 years seizure-free because of that. I am trucking. I'm moving along with it and living with it. Not struggling with it, living with it.
This is part 1 of Nancy's story. On the next episode of Epilepsy Ends, Nancy talks about her journey after diagnosis and what to do when you have to start everything all over again.
That basically, I was terrified before my surgery because there was no way to say this is how you're going to be when you get out, or this is what we're expecting when you get out, and that it seemed like a last resort.
Keep an eye out for our next episode of Epilepsy Ends, which you can expect on a monthly basis. You can subscribe on Apple Podcasts, Spotify, Stitcher, or wherever you listen to your podcasts. You can also visit efepa.org for more resources and to listen to more episodes of Epilepsy End. Epilepsy End is produced by Studio D Podcast Production with original music by Dylan Garvin. I'm your host, Missy Dalloway. Until next time.
Epilepsy End is produced by the Epilepsy Foundation, Eastern Pennsylvania.